Hi, my name is Amanda Rapacz, and I am the Director of Psychology as well as the Training Director at the Utah State Hospital. I'm going to give you a brief overview of our hospital as well as our internship program, and then talk about how that mapped onto the group specialty designation. So as you can see from this picture, the Utah State Hospital is a beautiful place to work. When I first moved here, I would often tell my friends back home in Chicago that I feel like I had moved into a postcard. We have an orchard on campus. We have deer and little ducks. We have a amphitheater that looks like a castle, and we have a fishing pond that our patients are able to use, and our rec therapists will actually use it for groups to help with negative symptoms and increase leisure skills. So it is not at all what people think about when they imagine a state psychiatric hospital. So we are the only state psychiatric hospital in Utah, and therefore we serve the entire state and the entire age span. We have a pediatric service area, and pediatrics serve 17 and under, and we have 2 adolescent units as well as 1 children's unit for ages 12 and under. There are a number of groups that are run over there: family therapy, individual therapy. We have a school that's part of the Provo School District, and so it's a pretty comprehensive treatment that our peds receive. Adult civil services, it includes 18 and over. Individuals on adult services are civilly committed to their mental health center, and when their mental health center feels like they need more intensive treatment, then the patient is then sent over to us at the state hospital. And our average length of stay is quite long, and that's to ensure that our patients truly are getting the treatment that they need in order to assist in their recovery, so that it doesn't become a revolving door of coming into the hospital, out of the hospital, into the hospital, out of the hospital, but really rather have them stable on their meds and also have skills that they need to live successfully in the community. We have a geriatric unit on the adult civil side. I think our age is a little young for geriatric. It's 55. I think 55 is still quite young. And it also includes individuals who are medically compromised, such as people who have Huntington's disease. We also have a treatment mall on our adult civil units, or our adult civil service area, and a number of group treatments take place there, which our interns are very involved with. And then lastly, we have our forensic service area. This includes not only the forensic units that are on campus, but also a jail-based program as well as an outreach program. The vast majority of people who are receiving treatment from our forensic services units are there because they're incompetent to stand trial, and the main goal is competency restoration. The Utah State Hospital has had an APIC accredited internship since 1997 and an APA accredited internship since 1999. And the mission of our internship program is to provide superior preparation for clinical independence, incorporating the highest standard of empirically based practice through comprehensive graduated supervised experience. And the reason our mission includes clinical independence is because Utah is a sequence of training state, meaning that we do not require postdoctoral hours in order to get licensed. You need 4,000 total hours. That can be any combination of pre and postdoctoral hours. And so we really want to ensure that our interns are ready to practice independently. Now, with that said, we do have 3 unique match numbers. We have a clinical match number, a forensic, and a clinical neuropsych one. And we really do have the goal of preparing our interns for specialty postdoctoral training within the area that they would like to be trained in. And so we're trying to constantly balance this, ensuring that they get that training while also ensuring that they're well-rounded generalists, they meet the professional-wide competencies, and that they are ready for independent practice. And so one of the ways that we do this is that we have primary and secondary rotations. The primary rotation is is what they match with. And this is often if they want a specialty postdoc, it's going to be that area. So you match with neuropsychology, you do neuropsychology training for the first 8 months of your internship. That's what you're doing as you're applying for postdoc. That's what you're doing once you go on postdoc interviews, and then you're wrapping that up, and you may finish that off with a clinical secondary rotation. Similar for forensics. Now, all interns are expected to complete year-long training experiences, and this is part of how we really ensure that they're well-rounded generalists and that they are meeting all professional-wide competencies. And so this year-long training experience includes both individual and group therapies, and we want all interventions to be evidence-based. So our interns will work with the same patient, same couple of patients throughout the majority of their internship until that patient's discharged, and then they'll get a new one, and they'll run the same groups throughout the year to really ensure that they're able to run that group according to the model. We do use recording, so they'll record their individual sessions. And then for groups, most of the time, your leader and co-leader are your intern and your supervisor. If it's not the supervisor, it's almost always another psychologist, and we complete fidelity checklists to ensure that we're running groups with fidelity to the model. So let's talk a little bit about how our program kind of fits with the group specialty designation. One of my big concerns as we started to look into this was the didactics. So we have a pretty set didactic schedule. We have didactics for the different specialty areas. We have generalist didactics, and the thought of adding more didactics was a bit overwhelming to me. But one of the things that I believe Rachel is speaking to is that we don't have to offer a didactic for everything on that list. One of the things that I do is I'll sit down with an intern and look at what their doctoral program has already fulfilled. There's no need to reinvent the wheel or take them back to something that they've already done. And so we can actually mark off a number of things just by going through that. Then we also we already had a number of didactics that were focused on empirically supported group interventions. So there's a list on the slide, but let's just take DBT for example. Our interns do comprehensive DBT, and there is 2 days worth of training for our interns on DBT. And in that includes roles of group leaders, who's appropriate for this group, what are the outcome measures, and they'll learn like, okay, the roles, the leader is going to be the agent of change. They're going to push the train on to get the skills taught for the patients. While their co-leader, right, is the agent of validation. They want to ensure everybody's on that train. So a lot of the didactic topics were also included in these empirically supported group intervention didactics that we were doing. We also spent and already had didactics geared towards test selection, how to use outcome measures, how to choose appropriate outcome measures for your individual and your group. So we found that we were actually meeting a number of these didactics already. Additionally, we do combine didactics with other training programs. And so that was another way. And then if there are gaps for interns, I can sit with them. We'll look at webinars that they can do, additional readings that they can do, and just find other opportunities to ensure that they meet all of those criteria that are required. When it came to the experiential component, our internship was already meeting and actually exceeding the expectations here. Our interns, as I said already, are required to run 2 groups as part of that year-long training experience. And they also typically have groups as part of their primary rotation experience as well. So the neuropsych interns often run a neurocognitive remediation group on top of their 2 hours of year-long group intervention. And so when we're looking at it, the minimum was really around 100 hours of groups that the interns were required to have. But it really ended up being more between 150 and 200 hours of groups. So we were more than meeting expectations there. And most of our groups are structured evidence-based groups. And we do have some less structured group opportunities, and I've also been getting creative about other group opportunities that are less structured, and ensuring that they understand the art of running group and can go beyond just the manualized based groups. So interns do already attend consultation groups. So if they're providing DBT, they're going to the weekly DBT consultation group. ACT has a consultation group that the interns would go to if they were running ACT groups. CBT for psychosis has consultation groups. And then we also have a psychosis track at the state hospital. And so interns who are running groups that were part of this multidisciplinary psychosis track would go to the psychosis track consultation meeting as well. Lastly, I just want to talk about how our interns were already having the opportunity to supervise others providing groups. Our psychiatric technicians run groups, and interns have the opportunity to assist and help and train and supervise the psych techs. We have undergraduate students just right up the street at BYU, and we have a special undergrad training experience where select undergrads can come over and work with a psychology intern, kind of see what it's like to be an intern, while also getting some exposure to group therapies. And so our interns are able to provide some supervision that way. And then graduate students, we have clerks, externs, practicum students. And so there's the opportunity to provide supervision with group interventions there as well. Having a group specialty designation, I think, has a number of positive outcomes. One of the ones that I really enjoy is that our interns who are interested in other specialty areas have felt that they actually are able to secure their desired fellowships because of their group training in evidence-based interventions. And so I think that's just a huge strength. The interns have reported really enjoying the group training. It's consistent feedback that we've gotten. And then lastly, I think it really has a positive impact on how other providers and our administrators at our hospital view our internship program. They really feel when we have that change of the interns, right? When our old interns leave and our new interns come in and they're not quite up and running yet, whether it's treatment mall or pediatrics, will frequently ask, when are they coming back? Or when are our new interns going to be ready? We need our interns. It's also a way to really ensure that we're providing groups with fidelity to the model, because we have leader, co-leader roles, and there's that supervisor and the intern together. And so from a training director viewpoint, I like it because our interns are getting that good training, but administrators like it because they know it's a cost-effective way to have a leader and a co-leader. So it's kind of, you get more bang for your buck that way, and I think that's a huge positive outcome. Really quickly, mapping our existing program onto the group specialty structure was really easy to do. I really enjoyed the didactic checklist. I think it's easy to use and really helpful. It flows well, it's easy to understand, and I think it really helped me be reflective on our group training opportunities at USH, both our areas for growth as well as validating what we're doing well. And so if you have a training program where you do a lot of group interventions, I'd strongly encourage you to look at the group specialty designation and see how your program fits. I hope everybody stays healthy and well. Take care.